Okay, everybody. Welcome to our next health psychology seminar presentation. I'm Zoe Mushkat, the health psychology intern at Jesse Brown VA. On behalf of Northwestern University's Feinberg School of Medicine and the Jesse Brown VA Medical Center in Chicago, I'd like to welcome you all to our next presentation in our 2020 Health Psychology Seminar Series. We have a great lineup of health psychologists, and our seminars will occur most weeks on Wednesdays at 2:30 p.m. Central Time through December 2nd. For those attending our live presentation today, of course, we're always so glad that you can join us. If you don't mind, just type in the chat box where you're joining us from so we can get a sense of who's tuning in. I also encourage you to ask questions in the chat box during the talk, and then we will go through them at the end for a Q&A session. And of course, since we're all on video, can you please make sure that your microphone is muted? Today, I'm honored to introduce Dr. Jason Ong, Associate Professor in the Department of Neurology at the Northwestern University Feinberg School of Medicine. Dr. Ong received his PhD from Virginia Commonwealth University, completed his internship in health psychology at Rush University Medical Center, and completed his postdoctoral fellowship at Stanford University School of Medicine. Dr. Ong is the author of numerous research publications and a leader in the field of behavioral sleep medicine with a focus on non-pharmacological interventions for insomnia and other sleep disorders. Please join me in welcoming Dr. Jason Ong.
All right. Thank you so much for the introduction, Zoe, and welcome everyone. I'm talking about behavioral sleep medicine today, and if you're like me and you stayed up late watching the elections, hoping you were going to get some kind of result, you might be sleep deprived, so this might be an appropriate topic for a day like today after the election. So what I'm going to do first, let's see if my slides will move. There we go. Okay. So what I'm going to do today is the first part, I'm just going to kind of walk through how I got to where I am and the route I took. And so I have here my career map. And later on, I'm going to talk about behavioral sleep medicine, kind of walk you through what that is and some different areas in behavioral sleep medicine that hopefully will be relevant to the type of things that you're doing in your area. So this map doesn't have red states or blue states, but it does have a list of different places that I've been. And as you can see, I've sort of been all around. And I think like a lot of people here that, you've probably gone to different places based on your education or job opportunities and so forth. So the nice thing is that I've had a chance to be in some different places throughout the country. I've actually been in red states and blue states. But it is kind of nice. As you can see, I've kind of settled here in Chicago for a period of time. So it is nice to be a little bit more stable. So I want to just kind of hit some highlights related to sleep and a few different things that have really influenced my career development. So actually in high school, I was already interested in sleep. This is an essay I wrote in ninth grade. I actually found this in my parents' home several years ago. I thought it would be fun to kind of look at it. This is actually the last paragraph of this essay I wrote in ninth grade, and I like the last couple sentences here where it says, as one doctor jokingly states, the best treatment for insomnia is to grab patients by the feet and shake them until all the medication has fallen out of their pockets. Perhaps that should be the treatment of the future. So I'm not sure I was preparing for a career in behavioral sleep medicine at the time, but and I don't know if we have evidence for this type of treatment yet, but I think this did set the stage for some of my interest in sleep. And this is actually my first job out of college. I actually spent a year working as a research technician at UT Southwestern. This is in Dallas. I was the guy that hooked people up and watched them overnight, making sure that we were recording their sleep, their EEG, and the polysomnography, as we call it. The project I was working on was looking at vets who had been diagnosed with Gulf War syndrome, so looking at their sleep. That's what we were doing in the sleep lab. And Roseanne Armitage here, I have a picture of, she was the PI of our lab. And so I learned a lot from Dr. Armitage here as my first job out of college. Now, I'll skip over here a little bit. I didn't actually do a whole lot in sleep directly during my PhD program, but on my clinical internship, which I did at Rush University Medical Center down the street from us here at Northwestern, is I was in the health psychology track, and one of the things that was appealing about Rush is they actually had this extended 6-month rotation in sleep disorders. And the director of the sleep lab at the time was Ed Stepansky, and he was also very influential. He was really an expert in behavioral treatments for insomnia. He really taught me a lot about doing CBT and treating insomnia, as well as evaluating sleep disorders. So this really reinforced my interest and really kind of honed me in on wanting to really follow behavioral sleep medicine as a career path. So from there, I went to Stanford University out in California, and this is where I did my postdoc. So here's where I got more in-depth training in behavioral sleep medicine. And I did both research and clinical work. I was actually on a T32, so it was primarily research. The research I was doing was on mindfulness meditation and insomnia. And the clinical work I did was doing CBTI, it's cognitive behavior therapy for insomnia, both individually and in groups. So that was sort of my training in behavioral sleep medicine. I actually came back to Rush for a faculty position in 2008 and kind of grew up there over the next few years. As an assistant professor, I got promoted and to associate professor there. Became director of the behavioral sleep medicine training program for several years. That was a lot of fun because I got to work with a lot of the psychology residents as well as my own lab and research coordinators and assistants. And then it was about 4.5 years ago in 2016 when I came over to Northwestern. So I'm an associate professor here. I'm housed under the Center for Circadian Sleep Medicine. That's where our sleep lab and most of the sleep research is. And I direct the Behavioral Sleep and Circadian Medicine Core. So we have the Behavioral Sleep Medicine Research Lab. We have a clinic at the hospital. And we actually have an accredited behavioral sleep medicine training program as well. So it's been fun to really get that set up here at Northwestern. So that's basically the path that I took to get to where I am. I want to talk now about behavioral sleep medicine, and as I said before, I want to give you a little bit of background in terms of where it came from, what it is, and thinking about where this comes from. There's really this interesting relationship between sleep and technology, and there's I remember reading a book when I was in college where the author really blamed a lot of our sleep problems on Thomas Edison. And so that's what I have here, and you can see he's looking at the light bulb. So of course, Edison invented the light bulb, and that really was a game changer in terms of a lot of different things. I mean, in many ways, you could say it really kind of, it really kind of exploded the Industrial Revolution. It allowed us to work at night. It allowed us to basically do things that you could argue is a little bit inconsistent with our natural rhythms, with really the way our biology regulates sleep and wake. But it also gave us a lot of opportunities to be able to do more things. So it sort of set the stage for this double-edged sword with technology and sleep. And I have here then the Wright brothers. Of course, you probably know that they invented the airplane. And with airplane, and now we actually had a means in a vehicle to be able to travel faster than our brains could adjust. So this created jet lag. Jet lag is a sleep disorder that is completely, a human creation. Because before we had airplanes, we couldn't move fast enough where our brain couldn't adjust to the new time zone. And then down here I have, I'm sure you know who this person is, Steve Jobs, holding up an iPhone. We now have the iPhone 12, which I'm sure he would be proud of. And I think what the iPhone really did, and these smartphones, is really revolutionize how connected we are to things that can basically keep us up for 24 hours. There's sort of this joke that everyone sleeps with their phone. That's why I have this picture here. But the bottom line with all this is that, with technology, there's many things here that have made our lives easier and have really created some advances. But at the same time, it's challenged us in different ways that really, I think, in my opinion, challenges our biology and our behaviors in terms of how our body regulates sleep and wake. So the other aspect of sleep medicine is that it really has its roots in psychiatry. And you might be wondering, why I have a picture of Sigmund Freud, especially someone who does mostly CBT. But what happened is around the 50s, and around the 40s, when they were just starting to do sleep research, and it was in the 50s, if I remember correctly, where they actually discovered REM sleep. This was actually a breakthrough in psychiatry because at the time, psychoanalysis was really the predominant form of psychotherapy. And they actually thought that REM sleep could be a potential biomarker for psychoanalysis. So they thought it might be a pipeline into the subconscious, the unconscious. It maps on, quite well with some of the psychoanalytic theories with the id, the ego, and the superego. So they were really excited about this. As it turns out, sleep medicine ended up going in a different direction. REM wasn't actually a biomarker, but it is interesting that a lot of the roots of sleep medicine still come from psychiatry. And where psychology and clinical psychology comes in, I would say, is focused more on the treatment of insomnia. So this is sort of a map in terms of the evolution here of how psychology has played a role in sleep medicine. So starting in the 30s, you had Jacobson, which he put out this book on relaxation and insomnia, which you could argue was one of the first behavioral treatments of insomnia. And then in the 70s and 80s, when behavioral therapy was really growing, there was a parallel in the sleep field. So this is when sleep hygiene became popular, the stimulus control instructions by Dick Bootson, sleep restriction therapy. These are all components of what's now cognitive behavior therapy. But these behavioral strategies actually came about in the 70s and 80s. It wasn't until the 90s when Charles Moore put these things together into cognitive behavior therapy for insomnia, what we now call CBTI. And, of course, now that's really the predominant treatment for chronic insomnia. And as we move, here into the 2000s, I would say that in the first decade, there was quite a bit of focus on insomnia and comorbid conditions, especially seeing if treating insomnia can have impact on other conditions such as depression. And I would say within the last decade, there's been more focus on implementation science, meaning how can we rule out CBTI? And I'll talk about some different versions of that using the internet and web-based delivery and other things such as step care models, things that are scalable. So that's kind of where the evolution of clinical psychology and insomnia happened. And now, I would say we have a pretty thriving field in behavioral sleep medicine. We have a Society of Behavioral Sleep Medicine. We call it the SBSM. You have the website here if anyone is interested in taking a look at that. We actually have a board certification in behavioral sleep medicine. It's now called the Diplomat in Behavioral Sleep Medicine, or the DBSM. And I also have the website there. And about 6 years ago, I believe it's been 6 years now, the APA actually recognized sleep psychology as a specialty within the APA list of specialties. It really has gained quite a bit of prominence if you think about where it came from psychoanalysis. And a couple of years ago, I had the opportunity to be president of the SBSM, and one of the things I wanted to put out there was really this concept map of what behavioral sleep medicine is, what the scope of the field is, and some strategic priorities. So as you can see, we actually have quite a bit of activity in these different areas, such as science, practice, regulation, and education. So as I mentioned, behavioral sleep medicine is really a thriving field. So, now that you have a background of what behavioral sleep medicine is, let's talk about what a sleep psychologist does. Many of you are probably interns and students and maybe postdocs who are looking to launch a career. Hopefully some of the things I tell you here might actually interest you in doing some work in sleep, or maybe even going and getting credentialed in sleep psychology. But I think probably, the best starting place to think about what a sleep psychologist does is really to try to help someone like this guy over here on the left who's trying really, really, really hard to fall asleep. So it's working with people with insomnia. So, that's really kind of the core of behavioral sleep medicine. It's really where it grew out of. And what I'm showing you here is really a landmark paper that came out, at least in behavioral sleep medicine. It's a landmark paper. It's the management of chronic insomnia disorder that was published by the American College of Physicians. And if you'll see here under recommendation 1, let's see if I can. Well, you probably can't see my cursor. But anyways, you can see recommendation 1 hopefully on your screen. You'll see that the ACP recommends all adult patients receive cognitive behavior therapy for insomnia, CBTI, as the initial treatment for chronic insomnia disorder. So this is really big because this isn't a group of psychologists or even a group of sleep specialists that's saying that CBTI should be the first-line treatment. This is a group of physicians. And if you're not familiar with the ACP, they're really the main governing body for primary care docs, for internal medicine docs, for family practitioners. So these are the people that are on the front line that for many, many years have been prescribing medication. So this puts it front and center of that, like, look, if your patient has chronic insomnia, they really should be getting CPTI and not sleep medication. And you'll see in recommendation 2, it's actually a pretty weak recommendation for sleep medication because it says that the ACP recommends clinicians use a shared decision-making approach, including a discussion of the benefits, harms, and costs of short-term use of medications to decide whether to add pharmacological therapy in adults with chronic insomnia in whom CBTI alone was unsuccessful. So, again, it really steered people towards CBTI. And I've seen a difference in terms of the referral sources. I've seen a lot more primary care docs that are referring folks to someone like myself in sleep medicine to get CBTI. So, some of you might know about CBTI. Some of you might be relatively new to it. So I just wanted to give everyone an overview here. So when we're talking about CBTI, it is a multi-component treatment that uses both cognitive and behavioral strategies. I would say predominantly they're behavioral strategies. The first 2 really are kind of the core behavioral strategies. So sleep restriction. This is something that's a little bit counterintuitive, but the idea here is to actually reduce your time in bed. Most people with insomnia do the opposite. They actually try to spend more time in bed, but that actually works against the natural regulation of sleep because there's the homeostatic pressure, which is similar to an appetite for sleep that actually accumulates when you are not in bed. So by actually reducing your time in bed, you can take advantage of that drive or that appetite to your advantage. And so this is usually one of our key starting points. Stimulus control, this is something that many people have probably heard of. These are the instructions of getting out of bed if you're not sleepy. The key to all this is really recognizing what sleepiness is and what it feels like for the patient. Because the idea is really you shouldn't be in bed unless you're sleepy. And if you're in bed and no longer sleepy, it is best to be out of bed. So there's a lot of nuances to that, in my opinion, but that's the basic premise there. And it's to reestablish the bed in the bedroom as a more positive stimulus for sleep. Sleep promoting, that's why you only do it when you're sleepy, rather than the negativity that oftentimes comes about as you're having repeated nights without sleeping very well. Sleep hygiene officially is part of CBTI, but to be honest, it's a pretty small part of it. I know that the term sleep hygiene gets thrown around a lot. One of my pet peeves is that oftentimes non-specialists use this synonymously with CBTI, but it's really, sleep hygiene is really a pretty small component of it, and it really is just a list of do's and don'ts to try to eliminate habits that are counterproductive for sleep, like drink coffee too late, try not to exercise too late, these type of things. But by themselves, they usually don't do a whole lot for sleep. So actually in research studies on CBTI, we often use sleep hygiene as a comparison group. That's how little we think of sleep hygiene as sleep specialists. And then you get into things like cognitive therapy. This is probably one component that requires a little more mental health training that's more suitable for psychologists or social workers because we have a little more background and training in trying to help people address these maladaptive thoughts. So, for example, some people really feel like they need 8 hours of sleep at night, or else they can't function well the next day. I mean, the reality is that it probably helps to have, something around 8 hours, but it's not a requirement. And in a short-term basis, you can still function the next day, even if you didn't get 8 hours. So focusing on that goal is usually not going to be helpful and probably going to make the problem worse because you're just going to make yourself more anxious when you don't get it. So that's kind of where the cognitive therapy comes in. And then relaxation strategies, so these aren't specific to insomnia, but just other things such as deep breathing, progressive muscle relaxation that can help people reduce that hyperarousal that oftentimes comes about with insomnia. And sleep education, this isn't officially part of CBTI, but it's something that I do that I think is really important to help people understand some of the things I explained earlier about why it's important not to spend too much time in bed, because it actually works against your natural body's regulation of sleep and wake. And so helping people understand the science of sleep, because CBTI really comes from the science of sleep, I think really establishes credibility and distinguishes CBTI from other forms of psychotherapy. Because sometimes people come in to see me thinking that I'm going to teach them some kind of gimmick or trick to lull themselves to sleep, and that's really not what I do. All right, so just to talk about the empirical support, so there really is quite a bit of empirical support at this point. This is actually a summary that now is almost 20 years old. As I'm looking at that. But there's now several meta-analyses that have shown that CBTI is quite effective. In general, there are moderate to large effect sizes. Just kind of a quick summary is that about 3/4 of patients do benefit in terms of significant benefits from CBTI. Generally, CPTI is better at reducing wakefulness. So SOL in the sleep world stands for sleep onset latency, not something else you might think of. And then WASO is wake after sleep onset. So we're usually pretty good at decreasing wakefulness in bed by at least 50%. We're not quite as good at increasing total sleep time. Here you can see that in general, it's only increasing about 30 minutes or so. But one of the main benefits of CPTI is that we teach people skills and tools that they can then apply on their own even after we terminate treatment. So the long-term effects of CPTI are really where it outperforms medication, because with medication, not surprisingly, when you're not taking it, it isn't really helpful. But CPTI, what we really try to do is empower the patient to be able to take it, to be able to work and manage their own sleep issues so that they don't have to keep coming back to sleep masks. And this is a meta-analysis we did. I'm just showing you this because it's not just for primary insomnia, but CPTI really works quite well for comorbid conditions. So this was a meta-analysis we did that got published in JAMA Internal Medicine, where we looked at CPTI across all sorts of comorbid conditions. Some of these are medical, like cancer, and substance use, alcohol dependence, chronic pain. The others are more psychiatric, PTSD, and so forth. But if you look here, we had this, we used some validated criteria for remission, and basically the remission rates are about 2 to 1 in favor of CPTI. So about 36% for CPTI is a remission rate versus controls, and these are all sorts of controls. It could be active, it could be sleep hygiene, it could be nothing, but the average rate is about 17%. So it really does reinforce how effective CPTI is. And something that's probably more relevant now is this is a nice paper that is published in Sleep, which is a non-inferiority trial of telemedicine delivered CPTI versus face-to-face. And this is, I think, the best way to summarize it. If you're not familiar with looking at these diagrams for non-inferiority trials, what you want to look at here, let me see if I can pull out my laser pointer. So basically here at the 0 point, everything to the left here favors the telemedicine, and everything to the right, the positive numbers here, favors the face-to-face. And they have a non-inferiority margin defined at 4. So what you're looking for is the entire range here. I think this is a 95% confidence interval. Is it all to the left of this margin? And the answer at post-treatment and 3-month follow-up seems to be yes. And then they have here the means, and so you can see the average effects of the difference here in the ISI, the insomnia severity index, by the way. It slightly favors the face-to-face. But basically, the bottom line here is that telemedicine delivered CPTI does seem to be about as effective as face-to-face, and it doesn't seem to be inferior. So that's very helpful, especially since now a lot of us, myself included, are actually doing CPTI using telehealth. And besides just the video delivery, there are digital apps. So this is one actually by the VA that's called the CPTI Coach. It's a pretty nice program. It's free, and it has different tools that people can use. My understanding is that it also can integrate with a clinician. So you could have the patient keep some diaries, and as a clinician, I believe you can actually receive those diaries. So it's a nice integration there with someone who is providing CPTI. And I think that was the original intention of this. This wasn't really designed to be a standalone program, not an automated one. It was designed to be really a tool to be used with some kind of face-to-face delivery. And I'm showing you another product here. This is called Somnus now. It used to be called Shut Eye, but this, to my knowledge, is actually the first FDA-approved digital CPTI program. What's interesting here is that it actually requires a prescription, and I think there's a little bit of debate about that. It sounds like for right now, the prescription needs to come from a physician, which I think is not really well served because I think there's a lot of mental health providers that know enough to be able to recommend this. But at any rate, I want to show you this because it is interesting. The FDA is now getting involved because they realize that CPTI is potentially considered a medical intervention, since insomnia is sort of a medical, sort of a psychiatric condition, but they're actually starting to regulate some of these programs now. And this is a meta-analysis and systematic review of these digital and web-based delivery versions of CBTI. And the summary here is that generally, if you look at effect sizes, they're about as good as face-to-face. The one area where there's a little bit of drop-off with the internet-delivered CBTI is with retention. So it does seem that attrition rates are a little bit higher in these web-based delivery studies. And that's not terribly surprising because some people may not, they may not be as engaged, they may not be as familiar with using web-based programs and so forth, or they're just not, they're just not as used to sort of a self-paced learning type of model. So that is one area where I would say face-to-face is still better, right? You have better engagement from the patients, and I think it makes sense intuitively. But there are some other studies that are showing that the attrition rate actually is not really that much worse. So I think the jury's still out on that. Besides CBTI, I just wanted to just talk about this real quickly. The research I've done is on mindfulness, and we actually have developed what we call a mindfulness-based therapy for insomnia. We call it MBTI. I was fortunate enough to write this up as a book that the APA has published. Recently, actually, we were able to get this translated into Korea. So I had a former mentee of mine, Ali Soo, who is in South Korea, actually was able to translate this over to Korean. So really nice to see this now into a different language. And, mindfulness, I think a lot of people have heard about it and they associate it with relaxation and calmness and so forth. But there actually is quite a bit of evidence suggesting that it can improve sleep, particularly with self-reported sleep quality, these global measures of sleep and insomnia. We actually wrote this article that was published this past year in Current Opinion in Psychology, where we sort of did a review of reviews. That's kind of where the literature is now in this area. And generally speaking, the outcomes for self-reported sleep is actually pretty strong. The effect sizes are moderate to large. If you're looking at objective measures of sleep, it's more equivocal. But that's actually not too different than the literature for CBTI. So I think at this point, I'm hoping that it will make it into some of the guideline treatments for insomnia, at least as a potential viable alternative to CBTI. So I think where we need more research in this area is to see who might be a better candidate for mindfulness versus traditional CBTI. Okay, so, insomnia still is sort of the main area, but there are still other types of sleep disorders, and there, I think, is a role for psychologists in other areas. So I want to kind of walk through some of those. So obstructive sleep apnea is probably the second most common sleep disorder. As you might know, CPAP, or it's continuous positive airway pressure, or PAP, some people call it that, is really the main gold standard treatment for sleep apnea. So CPAP really is very efficacious. The problem is that it's not very effective. And the thing is that, when you use the CPAP machine, that it does essentially resolve your sleep apnea. But the problem is that, as you can see here, only about 40 to 50% of patients actually use it on a regular basis, and the average use is only about 4.5 to 5.5 hours per night. So, if you think about the fact that most people sleep about 7 or 8 hours, that's really not great use there. And there's a lot of barriers to adherence, so it's just not comfortable. It's not the sexiest thing to wear when you're going to sleep. Some people don't perceive any improvement in their daytime functioning. So if that's the case, why bother to use this, this mask at night? And in some cases, when people travel a lot, it's difficult to remember to bring it along. So there's these different barriers. And what's also really interesting here is that Medicare has said that, look, we want people to be able to use this, and if you're not going to help yourself, we're going to take it away. So they've established this rule for regular use where you have to wear it at least 4 hours per night for a 30-day period within the first 3 months. And if you don't, they'll either force you to repeat it and go through the process again, or they'll actually stop paying for your CPAP machine. So this really put an emphasis on improving adherence to CPAP. And so that's where a lot of the other work in behavioral sleep medicine has really come from. I would say this is sort of the second main pillar, is using different health psychology models to improve CPAP adherence. So this is a nice review that they did looking at 30 studies, which had over 2,000 participants. And just to kind of give you a quick summary, it's really kind of a dose response category that they had here with just education itself. As you can see, just doing that will give you a little bit of an increase, about 35 minutes of use per night with CPAP. If you provide something a little bit more intensive, some support, some feedback, and so forth, you could then increase CPAP use by 50 minutes per night on average. And if you do some kind of behavior therapy, and really I would call this cognitive behavioral therapy because these are using things like motivational interviewing, social cognitive theory, really kind of aimed at improving self-efficacy, so the type of stuff that those of us in health psychology know about in other areas, you can increase CPAP use by almost an hour and a half per night. So, not surprisingly, it kind of maps onto this idea of a dose response and suggests that, the more psychological intervention you provide, the greater your adherence to CPAP. So there's some other areas I want to get to. One is parasomnia. So parasomnias are the more unusual things that happen at night during sleep, sleepwalking, night terrors, things like that. What I'm going to talk about here is actually with repeated nightmares. And there's a technique called imagery rehearsal therapy. It's actually a really effective treatment. And I wanted to mention this because this, I think, can be done with people who are not sleep specialists. So as I'm sure most of you know, nightmares oftentimes occur in the context of PTSD. So this can come up, in a PTSD clinic. And the background here is that in IRT, imagery rehearsal therapy, nightmares are treated like bad habits. So they increase in frequency just due to repetition. The more you have it, the more likely you are to have more. And that it's possible to eliminate nightmares by practicing new dreams that can replace these nightmares. Again, just sort of like you can replace a bad habit. And it's important here that, it's not just thinking about dreams, but using the mental imagery really activates different parts of the brain that can replace the nightmares. And it's best to do this type of practice when you're awake. So it's not something that you do like right as you're trying to fall asleep, but, it's best during the daytime because there your conditioned arousal is lower, your frontal lobes are in better control of your emotion regulation centers. And it's self-directed so that the voluntary control really is involved in the practice of creating these new dream scenarios. So just to kind of walk you through how this is done, the first thing you usually do is you are working with your patient or client, and you want to pick a nightmare. And usually pick one that's sort of like a mid-tier. It's not the most frightening nightmare, but it's probably not like the most benign nightmare, but something kind of in between. And then you get them to write down the new dream. So you say, hey, look, take your nightmare, write it down. And then change your nightmare in any way. Okay, you can change it by changing the ending. You can change the characters. You can, you can even create a whole new dream if you want to. So, it's whatever you want, and you get them to write that down. And then the third step is you get them to rehearse it. So you ask them to just sit there and really try to create, in as vivid, as possible, the images using all your senses. And again, you emphasize the difference between just thinking about it, but really trying to create that visualization, because that's really what enhances this. And after they do that with you in session, oftentimes this is done in vivo, then you ask them that, at home, I want you to practice this new dream at least twice per day. It doesn't take very long. This is only about like a 3 or 5 minute exercise. And it's also important never to rehearse a nightmare. And so what's really interesting with this, I've done this several times now, is that oftentimes what you hear from patients when they first do this is that they'll start to see some changes in their nightmares. And, one of the main things with nightmares is that they're quite rigid, especially ones that are associated with trauma, that they're always the same. But, one thing I've heard is that, like, the ending starts to change. I can remember this one patient I work with where his nightmare was that he would get eaten by a shark. Every time that's how his nightmare would end. And one day after we did this, he came back, I think this is a couple sessions later, he said, it's interesting, like last night I had the same nightmare, everything was the same in the beginning, but at the end, rather than getting eaten by the shark, I pulled out a gun and shot him. And then I woke up at that point. And so once you start to see more flexibility in the nightmare, then that rigidity that comes with the trauma usually starts to dissipate. So I've actually found this to be a pretty effective technique that, for those of you who may be working with trauma patients and PTSD and people who suffer from nightmares could actually use even without being a sleep specialist. There are practice guidelines now for the treatment of nightmare disorders. You can see here that IRT actually is a level A So this is the recommended treatment. It's at the same level as prazosin, which would be the main pharmacological alternative to IRT. And this is a position paper that came out just a couple of years ago. They basically reiterated some of the same thing. They also suggested that you can actually add CBT-I for people who have nightmares and sleep disturbance. So that combination seems to be quite helpful for people who have PTSD. All right. So the other sleep disorder I wanted to just spend some time talking about is narcolepsy. So most people probably know of narcolepsy as being a condition where people are excessively sleepy. They don't always just kind of have these sleep attacks where they suddenly like collapse from sleepiness. It's usually not quite as dramatic. But these are people who are chronically sleepy, and it doesn't matter how much sleep they get at night, they're still sleepy during the day. So it's not just due to insufficient sleep at night. Interestingly, people can have some symptoms of insomnia, and they often have these things like sleep paralysis and hypnagogic hallucinations. So hypnagogic hallucinations are having hallucinations as you're falling asleep. And this seems to be an intrusion of REM, where you tend to have things like muscle paralysis and dream agitation, and it seems to be an intrusion of the REM stage into wakefulness. So that seems to be what accounts for these type of symptoms. There's now narcolepsy type 1, which is people who have cataplexy. This is where they suddenly lose their muscle tone when they're awake. Again, this seems to be a symptom of REM because during REM, your brain actually shuts off your muscle tone. And then type 2 is people who have narcolepsy without cataplexy. And the symptoms can be variable. They can wax and wane and occur in different frequencies or different levels of severity across individuals. And there are a lot of good medications for narcolepsy, mainly at promoting wakefulness. You're probably familiar with different stimulants like methylphenidate, which is Ritalin, and then modafinil, armodafinil, which is Provigil and Provigil. Sodium oxybate is Xyrem. So this is actually GHB, which is oftentimes associated with the date rape drug. But this actually is a very effective treatment for narcolepsy in that it seems to consolidate sleep at night and can actually help reduce cataplexy during wakefulness as well. The thing is that we have some of these good treatments for narcolepsy in terms of wake promotion, but people who have narcolepsy still have a lot of issues with psychosocial functioning. So you can see here, in the slide, this is from Narcolepsy Network, which is a patient organization, that there's a real dramatic impact on their lives. You can see it says this comment here, even with treatment, people living with narcolepsy continue to feel the impact of their symptoms. There's different things here. You can just read some of these stats. 40% say they don't discuss it with their healthcare providers in terms of how narcolepsy affects their daily lives. Here, 88% say that people don't understand how disruptive narcolepsy is. You can see here even 37% reported having a failed class at school or withdrew from the class. 76%, three-quarters, said that narcolepsy has affected important moments in their lives. So, just the condition and the symptoms really seems to have a strong impact on the quality of life. And this caught my attention. And this is where I started trying to see if we could get in and do something from a behavioral sleep medicine standpoint for these people with narcolepsy. So the first study we did was actually a survey study just to see, would people be interested if we develop a program for hypersomnia? And you can see here, overwhelmingly, they said yes, they would be at least somewhat interested or extremely interested. About three-quarters said that they would be. So this kind of gave us a little bit of momentum to try to see if we could develop a program. We did a study here, which was a mixed method study to get some qualitative data because we really wanted to get a better understanding of how narcolepsy really is affecting their quality of life. And some of the main things that we found here, I'm just showing a little cross-section here of our findings, is that they found that they felt like they really had a lot of conflicts or lack of self-identity. Some people with narcolepsy said they were hesitant to talk to other people about their diagnosis. They felt it was an invisible illness that they were suffering, but they, really other people couldn't tell, what they had. I like this quote that somebody gave us, which is, "I get tired trying to explain why I'm always tired." And this has a negative effect on self-esteem as well. So many people talk about low self-worth, low self-confidence, and it really impacted self-efficacy. They felt that they were less capable compared to either their peers or compared to where they used to be. So you see some people even say that they're ashamed of having narcolepsy. And this quote here is a nice one. "I tend to focus on who I want to be, but I need to focus on who I am." So with all this, we got some money from the American Academy of Sleep Medicine Foundation to try to develop this, what we consider to be an adjunctive treatment for hypersomnia that's aimed at the psychosocial aspects of it. So this was a feasibility study, really to try to figure out kind of if you build it, will it come? We put together this 6-session version of CBTH. I'm not going to go through all these different components, but we had it set up where it's module-based, recognizing that people with narcolepsy might have different symptoms. So we try to make it where it's module-based so that a clinician could pick and choose whatever module is most appropriate with the symptom profile of the patient. And we had 35 people in this study. We also tested an individual versus a group version of the CBTH. And the other thing is that this is all delivered via telehealth. We realized that narcolepsy is still considered a rare condition, so we thought recruitment might be challenging. And there really wasn't a good reason to do this in person, so doing it via telehealth allowed us to really reach our scope and make it more scalable so that we can reach people across the U.S. So I'll just show you a couple of highlights here. One of the main things we were looking at is to see if we could improve symptoms of depression. So we had a PHQ, and you can see here that our effect size was quite large, or at least with individuals in the medium range. And these are statistically significant differences from baseline to post-treatment. We really didn't focus on that so much as we did just to get a sense of what the effect sizes were. We actually did get a significant reduction in sleepiness, which wasn't even really our intention. We weren't really trying to treat narcolepsy per se. We just wanted to try to improve the quality of life. And our main measure of quality of life was the PROMIS scales. And I'll just highlight this. You can see that what really stands out here is GSE. And this is the global self-efficacy, or general self-efficacy. And this, we had sort of this a priori cutoff of a Cohen's D at 0.5, kind of a medium effect size is what we felt would be what we needed to see if this really merited taking it to the next step, which would be a randomized controlled trial. And we were really happy to see that we were able to get increases in self-efficacy because in our thinking, this is probably going to be the psychological mechanism. You heard me say earlier that people with narcolepsy really felt like their self-efficacy was down, that they weren't as capable as they used to. So part of what we wanted to do in this program is to be able to empower them, help them feel like they're able to still function well despite having narcolepsy. So this gave us, some preliminary data to work with. And right now we have another study. This is actually, we call this ASCENT. This is using mindfulness-based interventions, really focusing on MBSR, which is mindfulness-based stress reduction. This is kind of a standard mindfulness-based program. But in this study, what we're trying to test is different doses or different versions of that traditional MBSR model. Usually it's 8 weeks, so that's actually our standard condition here. But with people with narcolepsy, we're not sure if they could actually handle all 8 weeks, if we can shrink it down to 4, or even extend it to 12 weeks. So we're trying to test these different versions. This is also done using telehealth models, so we're doing it actually through Zoom in this study. And this is an ongoing study. So if you actually know of anyone who you think could be a good candidate, someone who has narcolepsy, and they also have to have some symptoms of depression and anxiety. But if you know of anyone, you can certainly refer them to us. We have a study email, which is ascent@northwestern.edu. And I'll give you my email address later on as well. You can certainly email me if you have any questions about this or think you have someone who you might want to refer. And the nice thing is that I know people in the audience are all over the country. This study is also open to people around the country as well. So it's not just people in Chicago. Okay, so just to wrap up here, I've talked a lot about what behavioral sleep medicine is. Hopefully I have interested some of you in possibly pursuing a career in behavioral sleep medicine, or at least getting some training in these different aspects related to sleep. So where can you get training? Well, I would say start by looking at different accredited training programs. I mentioned that at Northwestern, we do have an accredited training program. The Society of Behavioral Sleep Medicine does have a list of different accredited training programs. I know many of you are probably at the tail end of your training, but if you're thinking about postdocs or even looking at internships, there are some programs there that offer those types of training opportunities. So the website's there, behavioralsleep.org. There are also ad hoc trainings. So I know at University of Pennsylvania, they offer a lot of workshops, I think at least twice a year on CPTI, and they're really good. They're led by Michael Perlis, who's one of the experts in behavioral sleep medicine. There's also several online courses that are available. I'd also encourage you to join associations. So I've mentioned a couple of these, the SPSM. There's also the Sleep Research Society. So if you're more focused on research, they have a lot of grants. They really do a lot for trainees. They have a really nice trainee day as part of the annual sleep conference that if you're interested, I'd encourage you to attend that. The American Academy of Sleep Medicine is another group. And for those of you who attend ABCT conferences, it's the Association for Behavior and Cognitive Therapy. There is an insomnia SIG group there, special interest group. And even though it's insomnia, I think now they call it insomnia and sleep disorder, so they do include other sleep disorders there. And if you're really motivated, I'd encourage you to attend sleep conferences. So the next version of our annual sleep conference, this is an international sleep conference in 2021, is scheduled to be in Seattle. We'll see where things stand with the pandemic at that point. And there's also the World Sleep Society. Their upcoming meetings are in Rome in 2022 and in Rio in 2023. So the other nice thing about sleep is that we tend to have our conferences in some pretty fun places. So you get to travel a little bit to fun places around the world. And finally, I mentioned this before, but I'll just reiterate that there are some professional credentials, and you can get board certified in behavioral sleep medicine. Right now, since it's still relatively new, it doesn't necessarily mean anything. I mean, it's a distinction, but our hope is that if we can get a critical mass, eventually we can go to insurance companies and say, hey, look, reimbursement should be tied to someone who has a BDSM, because they really have the expertise and training to be able to work with individuals with sleep issues from a behavioral standpoint. So that's kind of our long-term vision. And again, if you're interested in this, the oversight is by the Board of Behavioral Sleep Medicine. It's technically a different society than the SPSM, but the website here is bsmcredential.org. So the last thing I'll say is that it's important to find a good mentor. I think you've probably been told this in your training programs. I've shown you mine, so hopefully you have one. And if you're interested in sleep, there's certainly different ways to network and connect with a good mentor in sleep medicine. So, hopefully you have some interest here. I do think that there's a lot of career potential. There are empirically based treatments, and one of the main problems we have here is that we don't have sufficient number of providers to deliver them. So there are jobs that are going unfilled. So from a business standpoint, I think that there's great potential. All right. So thank you very much for your time. And if you have other questions, I think we still have some time to take them now. I also have my email address over here. If you have other questions later on, you could email me. All right. Thank you very much.
I had a question, Dr. Ong. I was wondering if you ever recommend any user-friendly reading material or workbooks to any of your patients that do suffer from insomnia, and if you can give us a list if you do that.
So kind of like a bibliotherapy, like are there handouts or workbooks? Yeah, I mean, let's see. So there are some. I know that my former mentor, Rachel Lambert, and Colin Carney, I think, have one. I'm blanking on their name, but I think it's they have a lot of good cognitive strategies in there. I want to say it's something like, like Insomnia for Busy Minds. They've done research in insomnia and depression. So I think they also have some different activities for people who have insomnia comorbid with depression. Yeah, sorry, I'm blanking on the title, but I think if you do like a search for Colin Carney and Rachel Lambert, that book should come out. That's a good one. For clinicians, there's a really nice handbook for doing CBTI that Michael Perlis has published. That's really kind of like a nice, really kind of like a treatment manual, step by step, session by session. So that's probably geared more towards clinicians. I think they do have some handouts in there that you can give the patients as well. And then I think just some basic things like sleep diaries. If you're looking for just some forms, there is what's called the consensus sleep diary, which just means that at some point I think it's been about 10 years ago now, where a bunch of sleep experts got together and compared sleep diaries because they realized that we all did it a little bit differently. So they set up more of a standardized form. So there are those that are available. I think the American Academy of Sleep Medicine has some that are available. I think someone just posted Quiet Your Mind. I think that is the title of that book. Thanks for posting that. So does that answer your question, Dan?
Yes, thank you.
Okay.
Thank you so much for this presentation. I have a question that you might get a lot, but with the proliferation of consumer-grade actigraphy, how do you think that impacts the delivery of CBTI or the acceptability of CBTI?
Yeah, so you're probably talking about things like Fitbit, like wearable devices. Is that what you mean?
Yes, I do.
Yeah, great question. It's interesting. Like, I think it's been controversial in the sleep medicine field. I think for a long time, like we've sort of shunned those. It's sort of, and I think it's, like a bit from the standpoint of like, well, we've got our research grade actigraphy that we use in research. Those are much more accurate. The main difference, just so you guys know, is that the quote unquote research grade has 3 axes. And that third axis actually does improve accuracy quite a bit. The consumer grade usually only has 2 axes. But the trade-off is that the research grade ones usually are several $100s. The consumer grade ones are much more affordable. And I think as some of the technology has improved, especially when you combine it with other sensors like heart rate, things like that, the accuracy has gotten better. Where they still seem to kind of fall short is it still has some trouble distinguishing when people are very still and they're not technically asleep. And really, the gold standard is still polysomnography, and you need EEG to measure that. But I guess to come back to your question, I would say that the Sleep Research Society did put together a workshop, and they have a white paper that I think is published now, or at least it's in press, where they really do encourage more collaborations with industry, because now the technology has advanced to the point where I think that we do need to start paying attention to these. I think they could be integrated into clinical work. I think we're not too far away from the point where like they could upload their data from a Fitbit to a clinician. You could review it ahead of time and start to provide some recommendations from that. So I think that right now it's still kind of equivocal, but in the not too distant future, I think you'll see more integration there. And I think it's a good opportunity. These are not going anywhere. People are going to have more wearables. So it makes sense to try to use that rather than try to avoid it.
Thank you. That's really helpful.
One of the things that I noted when you were talking about the basic CBTI techniques was helping clients recognize when they're sleepy versus when they're not sleepy, so they should get out of bed for stimulus control. What are some of the techniques that you've used, or some of the questions that you ask to help your clients recognize sleepiness versus something else?
Yeah, really important question there. So I'll give you a definition first. In sleep medicine, we usually define sleepiness as the propensity to fall asleep. So you can think about it as the proof is in the pudding, meaning this is a state that most people would describe as feeling drowsy, where if they didn't fight it, they would likely fall asleep. And so when I say the proof is in the pudding, it means if you give somebody who is sleepy the opportunity to lay down and try to sleep, they should fall asleep very quickly. All right. So in sleep medicine, one of the tests we use to diagnose a condition like narcolepsy, where they're excessively sleepy, is we bring them into our lab during the daytime, and we give them an opportunity to take a nap every 2 hours. And we have them hooked up to our sleep sensor so we can see exactly how long it takes them to fall asleep. And if they fall asleep in less than usually 8 minutes or 10 minutes on average across these naps, that's considered abnormal sleeping. So that's sort of the objective version of it. I think just, if you're to explain this to a patient or a client, I would usually say that, look, think about, like, are you in a state where you're struggling to stay awake? And if you allowed yourself to actually sleep, would you fall asleep quickly? So there's sort of this idea of sleepability. It is kind of one way to think about it. But you raise a good point, because I can sit here and explain it. I can tell somebody what it means, but what's more powerful is for them to experience it from a first-person standpoint. So when I do CBTI, I spend a lot of time actually getting people to understand what that means. Because if you can get a sense of what sleepiness feels like and what it means to you, then you'll be in a much better position to follow any of the behavior instructions for CBTI. And if you don't understand it very well, then it's hard to figure out, like, well, when should I get out of bed? Because I don't know what sleepiness feels like. So yeah, in my opinion, I think that's actually one of the fundamental things, and oftentimes that's a starting point. Just typically, let's talk about sleep minutes, because if you can understand this, then I think the chances of doing well with CBTI are much better.
Thank you.
And I don't have the chat up on my end, so I can't see what some of the other questions are that are coming in. I'm sure there's others.
We have another one that says, can you briefly describe the difference between BBTI versus CBTI and why? As a provider, you would choose one to use protocol over the other protocol.
Okay. Yeah. So BBTI is something that was developed by Dan Bicey and colleagues at the University of Pittsburgh. Essentially, what they wanted to do is have a version of CBTI that could be delivered by non-specialists. I'd mentioned that in CBTI, the cognitive part is probably the part that requires a little more mental health training. But most people who treat insomnia are at the primary care level. And so what they were trying to do is make something that's more portable that we could implement at the primary care level, or something that would not involve a sleep specialist. So in their studies, I think their version of BBTI is like 2 in-person visits in addition to some phone follow-ups. And they had nurses and non-specialists go through it. And so I think their first study was on older adults. I think since then they've tested it in some other populations. So it is more brief in that you don't need as much in-person contact. The other advantage is that it should be pretty easy to train a non-sleep specialist. I don't think there's been a head-to-head comparison, so it's hard to say, how much more advantage that cognitive component has. There's been some other studies that have looked at dismantling CBTI, and it does seem that that cognitive component really plays out in terms of long-term effectiveness of CBTI. So I think those are some of the pros and cons, and probably has to do also with just sort of what the resources are. If you have someone who can do CBTI, that's probably good to start off with that. But if not, or if it's you're in a clinical situation where you don't have as much time, then maybe something like BBTI would be.
Hi, Jason. It's Sarah Denise. Thank you so much for doing the talk for us.
Hey, Sarah. Good to see you.
How are you?
Good.
I have a question of a bit of a different nature, but I know, I think last year you were having a baby during this talk, right? Or right around that time.
Right. Not me personally, but my wife, my partner, yeah.
Yes.
Unfortunately.
And, how did your sleep change, and is it back to normal?
Yeah, so fortunately, yes. So our baby is now, about 15 months. So, so one nice thing is being in this field, we sleep trained her pretty early on. And also, she's our second. We have a 3-year-old as well. So we learned that with the first one, he's still alive. We didn't do anything terrible to mess him up. So we were a little bit more aggressive in sleep training her earlier on. This is one of those things that, as a sleep specialist, I was willing to take on more risks just so we could get more sleep earlier on. But yeah, having babies, other just life events, you can certainly disrupt your sleep. But humans are pretty resilient. We've made it. We're still in the gene pool. So that does bring up the point sometimes with chronic insomnia that I explain to people. As humans, we are capable of dealing with short-term sleep deprivation. That's usually not what creates a lot of health consequences. It's the prolonged, long-term sleep depravation and really the inability to sleep that really that's associated with more long-term health consequences. But luckily, our kids are sleeping through the night for the most part. Now our problem is that our 1-year-old wants to stay up because she's jealous of her brother who's still up when she's going to bed. So,
yeah.
Yeah.
Well, that's great. Thank you.
Yeah. Thanks for asking. Are there other questions? Again, I'm sorry. I don't see the
chat. I don't see anything else. People saying thank you, and it was a great presentation. Thank you so much, Jason.
Sure. Yeah, happy to do so. And again, if anyone else has any other questions or just, you want to chat about behavioral sleep medicine or sleep psychology, my email's there. So feel free to reach out to me.
Thank you so much. It's such a I'm always so proud to be in the same profession as you because you are so knowledgeable on the topic, and and I think so many people have aspirations to be a clinician scientist, and you have really embraced that and been able to do it successfully. So thanks so much for taking time out of your busy schedule to come and talk with us.
No, no problem. My pleasure. And thank you for those kind words. So, I think I've been lucky to have a lot of good mentors, and, I think I'm just an example of the fact that, you get connected with people and, they can help you launch a career and take you to good places. So, yeah, so happy to pay it forward.
Definitely. Thanks so much, Jason. Thank you, everyone.
All right. Take care.
Dr. Ong.
Thank you.
All right. Bye. Have a good day, everyone.